Thank you everyone for joining us today on this Monday in late September. We're happy to present with you an overview of what we've been doing for the past couple of years with the National Dementia Workforce Study. I can get the slides to advance. There we go. So here's what we're gonna hopefully cover today. So what exactly is this thing, NDWS? Give you a high-level overview of the survey content, some of the linkable data resources, and then how to access the data and what's coming next for the project. I'll actually should say I'm Donovan Maust. I'm a geriatric psychiatrist at the University of Michigan and Ann Arbor VA, and I'm joined, of course, by Dr. Joanne Spetz at UCSF. And I'll start out with the first dozen or so slides and then turn it over to her, and we'll sort of go back and forth for the talk. So as background, probably most of you on this call know that there are a number of Americans with dementia, older adults with dementia, and that number is going to nearly triple over the coming decades. This is a costly population to provide care for, in some ways because of the unique features of dementia, with where older adults with this illness both have memory impairments, but also functional impairment. That means they need some assistance in managing their affairs. So by 2040, there are some estimates that the total cost of this care will be on the order of $1.5 trillion for the US. There are millions of workers who serve and provide care for this population who have a huge influence over the quality and the cost of care delivered. I think anybody on the call that's a clinician, or if you've had a family member who's experienced dementia, you understand that the type of care that they receive really is influenced in large part by who are the clinicians who are providing that care. So that's kind of the most important background for this project. A particular part of this workforce that's of great interest are direct care workers. So these are people who are really providing a lot of the hands-on care with job roles like personal care aides, nursing assistants, home health aides. And by far, this is actually the largest component of the dementia care workforce. Ultimately, while the NIA has invested a lot of money in surveys and population-based studies that focus on older adults and their caregivers, their family caregivers, we actually know much less about people who provide dementia care in their professional capacity and don't really understand how that workforce influences the care and outcomes of the people that they're providing care for. And so Joanne actually just emailed me over the weekend, was doing a little bit of inbox dive and found that it was basically 3 years ago that we first got in touch with each other about this funding announcement that came out from the NIA. And here's a quote from that announcement where it says, "What is missing from this literature is how care is supplied to persons living with dementia and the decisions what decisions are made by providers and institutions that lead to wide variations in the care that they receive." And so 3 years ago, the NIA put out this announcement, basically looking for a data resource for researchers to really be able to investigate these questions, to really understand the workforce that's providing care for persons with dementia, looking for a national survey that could be linked with patient outcomes and other administrative data, including funding for pilot grants to help accelerate use of this data, all in service of advancing the NIA's dementia research implementation milestones, and specifically one of the more recently added milestones, which is specifically focused on the dementia care workforce. And so 3 years ago, in our conversations with each other, ultimately what we assembled has turned into the National Dementia Workforce Study. So like I mentioned, I'm a geriatric psychiatrist. Joanne is a health economist who's internationally recognized expert in workforce, healthcare workforce research. We paired up with James Wagner, who's our survey methodologist, who's here at Michigan at the Survey Research Center. Our other core leads are rounded out by Laura Wagner, who is a PhD prepared RN who works in long-term care settings, and she's leading our pilot studies core. And then Steve Marcus is a longtime collaborator of mine from the University of Pennsylvania, who's really a guru around sort of linking different data sources and administrative data sources for research. We have a really large team between co-investigators and consultants. I think we're well over 30 from it's a really complex topic that we are trying to, again, build this infrastructure for researchers to use. And so we draw on a lot of different expertise from organizations across the country. And then one other kind of unique feature of this project is that the RFA from NIA required us to competitively and externally source our data collection agencies. So in our first year of funding, we had a call for proposals to actually select the organizations doing the data collection. And through that process, ended up working with RTI and DLH, who are actually fielding these surveys. And it's a 5-year project. We just started year 3 and go through the end of August of 2028. So part of the challenge for Joanne and I and the rest of the team was thinking about this incredibly broad request, the dementia care workforce. What does that even mean? What types of clinicians does that involve? What settings should we be focusing on? And so what we started with and ultimately developed is a family of surveys. And so the first survey we call the Community Clinician Survey, which is maybe not the greatest name that we came up with. Probably maybe 20 years ago, we might have called this a physician survey, but that is actually not accurate in terms of who's providing care, who are the clinicians caring for these folks. So this community clinician survey includes physicians, nurse practitioners, and physician assistants, primarily focused on outpatient care, but this is also where we include clinicians some of whom work in inpatient settings, some of whom work in residential care settings like nursing homes. And then in addition to thinking about those specific clinicians, we kind of talked through and thought through the different settings that are important for care delivery for persons with dementia. So obviously nursing homes are an incredibly important setting where these folks receive care. Assisted living communities are now perhaps have exceeded nursing homes in terms of their importance as a residential care setting for older adults with dementia. And finally, the home setting. This is an incredibly important place where people receive care potentially so they don't end up entering an assisted living or nursing home setting. And so with those 3 organizational settings, we included both a staff survey as well as a survey for an administrator to answer some characteristics about the organization. And then we decided to focus on specific types of job roles within those settings, thinking about licensed nurses like RNs or LPNs, as well as those direct care workers, nursing assistants, personal care aides. There are many job roles that are not included in that list. For example, social workers, physical therapists, occupational therapists, in both in the community as well in these settings. So you might say there are a number of roles that are not included in your survey that are really important. And I would say we agree. We had to start out though drawing some boundaries around who we were going to survey and where the focus would be. And then as the work goes on, if we have the opportunity, potentially we might expand who's included. And then as you can see from that last line of text, this is a really big project. So on the order of like 70,000, tens of thousands of surveys over the 5 years of this project. So now going through these surveys with just a little bit more detail, the community clinician survey, part of our challenge was thinking about like, what is dementia care? Who provides dementia care? Is it a cardiologist who cares for patient with dementia? Or is it a primary care physician who perhaps is involved in the diagnosis? And ultimately, we decided again to sort of narrow our focus a little bit here and think about the types of clinicians who conceivably would be involved in diagnosing a problem of diagnosing the dementia and or managing that dementia, as opposed to say a cardiologist again who is managing dementia as a comorbid condition. So we focused on primary care, including physicians, nurse practitioners, and non-surgical physician assistants, psychiatrists, and then mental health or psychiatric nurse practitioners, and finally neurologists. So we ended up with 6 combinations of specialty and license in our community clinician group. Using Medicare data to basically identify patients with dementia in the most recent year for which we had data. And then we sort of went up a layer to who are the clinicians who care for or prescribe to these individuals with dementia. This is by no means a perfect way of identifying older Americans with dementia. The bottom line, though, we were just trying to identify who are those clinicians who, in the course of their care, are likely to be caring for patients with dementia. And that's how we went about identifying them. For the staff surveys, so if you'll remember, we had the nursing home survey, the assisted living survey, and the home care survey. For these, we kind of started with the organization and we did that in a different way for each survey. For the nursing home survey, that was relatively straightforward because we could just use the list of CMS or basically Medicare or Medicaid certified facilities. For assisted living communities, this is less straightforward because unlike nursing homes, which are federally regulated, have a federal licensing process, assisted living communities, it's really a state-specific process. And so James Wagner and his team at the Survey Research Center went basically to all 50 states to obtain the licensing lists from those states to identify the assisted living communities within those states. In the first year, because we had so much startup work to do, we ended up, our survey sample was limited to a list of 21 states. And then in year two, we're expanding it to all 50 states. And then finally, home care. So this, Joanne will talk about this a little bit more, but the home care slash home health. So this is a very complicated area where there are people, say older adults who are receiving, say after they're discharged from the hospital and they need in-home home health for wound care or for antibiotics. That's home health. But then again, for patients with dementia who are having functional impairment, they need help with activities of daily living, which would be under the umbrella of home care. So the reality is that home health is a much easier sort of universe to get to because like nursing homes, home health agencies, which get paid through Medicare, are certified with CMS. And so our first year of this survey, we worked from the CMS certified list of home health agencies. We know that there's a little bit of an overlap, and some of those agencies also happen to provide home care. But ultimately, in year one, we were primarily surveying home health organizations. And then year two looks more like the assisted living survey, where we use state licensing lists of home care agencies for our year two, wave two sample. And so then for these surveys, we identify the organization, we go to the organization to recruit them to participate, and then we randomly select staff in the job titles of interest from those organizations. You do that because you wouldn't want to go to a nursing home and have them volunteer staff, because that would most likely not be a representative sample of staff in the organization if they're just sort of giving you a list of, say, their 10 best employees. And so once we engaged an organization to participate, they provided us a list of staff in the job roles that we were looking to survey, and then we randomly selected staff from those sample. Here are the job titles that we were looking at. I won't spend a lot of time on this slide, but again, we were interested specifically in licensed nurses and direct care. And so within those three different surveys, this is the list of job titles that we came up with that we thought were most consistent with the specific roles that we were looking at. And now I'll stop talking and hand it over to Joanne.
Great. So I'm going to talk a little bit about how we developed these questionnaires. I'm Joanne Spetz. I'm at the University of California, San Francisco, as Donovan mentioned. And we had quite a charge in our first year of work, which was to develop 7 survey questionnaires, one for the community clinicians, and then one for each of the staff in nursing homes, assisted living communities, and home health and home care, plus the administrators of the organizations and agencies in which those staff worked. So to do this, we began with, as any academic might, a very broad literature review. We all unearthed articles that we had stashed in our own files. We also did new literature searches. We found questionnaires and examples of them and so on, and ended up with over 120 articles and questionnaire examples from prior work that's been done by scholars all over the world, truly. We also looked at recommendations such as the Health Resources and Service Administration's recommendations for minimum data elements that can and should be collected by state licensing boards when they're renewing health professional licenses. There are a number of states that do that kind of minimum data set collection for one or more professions. North Carolina is being one of the longest and oldest running such example. And so there are some general standardized recommendations from that we took into account as we were developing our ideas. We also did a call for survey content to seek input and ideas. And in that first round, we received 38 responses. We've made this kind of a call every year since then. So we ask you to keep your eyes on your email in the spring for when we do our next call for survey suggestions, because we do read those very carefully and they are a big part of any annual updates and changes to the survey that we make. Some of these are going to be one-time special modules, and some of them may become permanent components of the survey although we have to be attentive to how long this questionnaire could be. We also then had survey design team meetings and reviews across different sub-teams, as well as 6 consultants and our project scientist at the National Institute on Aging, to have really solid draft questionnaires that then went through cognitive testing that was led at the University of Michigan Survey Research Center. And after the questionnaires were finalized, we had them translated into Spanish by professional translators. These all were placed on the website in summer 2024 once they were finalized and as they were going into the field. So you can see the full questionnaires there. Next slide, please. So the key domains, I think in many ways are not surprising where we landed for the first cycle of key domains. Clearly, demographic information is important to understand the workforce and how things like age, gender, family status, presence of children might affect other aspects like attachment to the workplace, decisions about how much to work, issues like where are benefits coming from, such as health insurance. We also ask quite a number of questions about education, training, and experience. Those questions are naturally different for clinicians than they are for frontline staff in nursing homes. But they include years of experience in working with populations that have dementia or have long-term care needs, fellowship and training, fellowship type specialty training that clinicians may have across all the clinical professions, nurse practitioners and PAs included. We ask questions about employment status for clinicians. Some of the questions include how much they work, how large their practice is, what kind of relationship they have within their practice. Are they locum tenens or are they permanent clinicians there? And for the staff and organizations, are they full-time, are they part-time? What kinds of shifts do they typically work, and so on. We also have standardized, for the most part, standardized questions about their knowledge of dementia care and their attitudes around dementia care. So for clinicians, we ask about the cognitive assessments they use in their practice. Who administers that? Is it them personally, or do they have, say, a social worker or a advanced practice nurse who administers the assessment? As they're doing an evaluation for cognitive impairment, do they refer the patient to another provider? Do they order specific kinds of tests, including biomarker tests, neuropsychiatric testing, etc.? For staff, we ask questions about their attitudes and views of working with dementia. Some of those questions are coming from standardized scales that have been used in the literature. We ask about their working conditions and their organizational practices related to dementia care, and then outcomes like burnout, sense of occupational safety, their intention to stay on the job for the foreseeable future, next 6 months, next year, 2 years or longer. So these items all together, we think, provide a really great starting point to start understanding what this workforce looks like. So next slide. We also have administrator surveys. So per the sampling design, we begin for the staff in recruiting their organization. And so their administrator is asked to complete a questionnaire that is really focused on things that you can't get in other sources. So we ask some questions about their practice setting and characteristics, whether it is a not-for-profit or for-profit organization, for example, how many beds they have, what the payment mix is for their beds. Do they get Medicaid residents? Do they have Medicare payments, etc.? The training that they provide to their staff, and then various other questions related to dementia-specific care as part of their hiring preferences, their training, their ongoing education. We also ask about the benefits that they offer to their staff, and various other questions about the workplace environment that you might not be able to get from administrative data sources, such as using the CMS data about nursing homes. Next slide. So for community clinicians, this is just a screenshot from the web version of the survey about a couple of the questions around for the patients with suspected cognitive impairment. How often do they order or refer to a specialist for ordering certain kinds of testing? And then among patients, how often do they refer patients to certain kinds of specialists? Since these surveys are going to primary care providers as well as specialists, the referral patterns should be really interesting, because we would not be surprised to see a neurologist perhaps also referring to a geriatrician or a psychiatrist for other assessments as part of the overall care for people living with dementia or with suspected dementia. Next slide. For the assisted living staff, this gives you a sense of a few of the questions about their workplace. The first set of questions there is their agreement or disagreement about their essentially overall support in their environment for the kind of care that they provide. Do they have enough time to perform various duties that are important for their population that they're working with? Does their supervisor tell them that they are doing a good job? Are they encouraged to discuss the well-being of their residents with their families? So some of these questions are really around their overall sense of being part of the valued team. We also have asked about some of their experiences with communication problems, disrespectful behavior from residents or family members, and some of these questions were expanded in some of these general context areas for the second wave of surveys. And then on the next slide, we can see for administrators that we have asked questions such as the benefits that they offer, as well as the kinds of training that they offer, and very specific domains of training that they might directly offer to their staff. So on the next slide, you can download, using that QR code, that'll go directly to the survey crosswalk, which allows you to easily compare the items across the staff and administrator surveys. It also includes the item source for when they came from pre-existing surveys. Of course, you'll see any number that we developed on our own or that we adapted from other questionnaires that were similar or kind of barking up the right tree but needed some adjustment in order to make them really applicable to this population. But you can look at those, and you can also see in there, I believe the Wave 2 questionnaires are also up there right now. So you should have that information available as well. So I'm going to hand it back over to Donovan to talk about the data that now has been released.
Yeah, so just in my final review of the slides, I needed to update our tense from data will be released to data were released, because I think this is the first talk we've done since we've actually released the data. So there are two versions that are out there. The first are public use files, or PUFs, and they're available through NACDA, which is the National Archive of Computerized Data on Aging, which is basically a NIA-funded enclave. All you need to do is enter your email address. Registration is really nothing more than that. In the public use files, because of the relatively few number of participating organizations for the organizational surveys, we do not release the administrator surveys. Since there's only one per organization, we thought that that was too few to feel comfortable releasing as a public use file. However, on the staff public use files, we did include just a small number of variables that we thought would be useful from the administrator survey, such as the ownership type. Is this a nonprofit or a for-profit organization? What we did to prepare these data files for release is working with Kate Spector-Baghdadi, who's a bioethicist here at Michigan. We sort of thought about essentially the disclosure risk protection process to help protect the identity of our respondents. And so obviously direct identifiers, the person's name, their address, none of that is in the data. But then there are other indirect identifiers, which are basically sort of observable characteristics like, oh, this is a male geriatric psychiatrist from Michigan. Like that really narrows your options down to who that respondent is. And so these externally observable indirect identifiers, we went through a process of either sort of collapsing variables. So for example, what year did you complete your highest clinical degree? Instead of offering that, 2001, we grouped that by decade. So that was one possible option, or we simply suppressed the indirect identifier if it led to it, if it increased the disclosure risk. There is on the website, the survey questionnaires now include the variables that have either been modified or completely suppressed. And there's about a one-page overview of our risk reduction process that will be more articulate than the description that I just gave you. So I would encourage you to look on the website and find that information. The full sort of unmodified, unaltered versions of the surveys are available on Linkage, which is, again, another NIA-funded platform where if you want to use NHATS linked with CMS data or HRS linked with CMS data, sort of any of these NIA-funded surveys where you want to do restricted, have a restricted environment to access the surveys and any linkable data, that now happens on Linkage. So now talking about some of the restricted data that are available. So I kind of think of this as 5 different families. The types of linkable data that are available are geographically linked data through using the state FIPS, state or county FIPS codes, and then using various types of CMS data that can be linked. And so the surveys that go into Linkage include encrypted versions of the state and county FIPS code and the federal CMS identifiers, which is how a number of these linkages are possible. I refer you here to the website where you can read more about, but I am going to walk you through some of this information right now. So the first type of linkable data is, like I mentioned, the unmodified versions of the surveys by themselves. Even if you don't want to link them to anything, those are available on Linkage. Or if you want to link the staff with the administrator surveys, those are available on Linkage. The next type of linkable data is environmental or geographic information. And so specifically right now in Linkage, what we have are some data sources available at the county level. So the area health resources files and something called the social vulnerability index that's prepared by the CDC and based on a number of census data at the county level. In addition, we have some state information sources. So the AARP Long-Term Services and Supports State Scorecard, which is released every year. We have that, all of those, I think it's about 50 different variables or characteristics that we have sort of bundled together into one single data source that's available, as well as a report on state level Medicaid spending, what proportion, how many dollars are spent in Michigan on Medicaid, how many of those dollars go to institutional care as opposed to home-based community services. That's also available. Next is a data source I'm sort of particularly excited about, and I'm hoping that the research community will find useful. And these are basically claims-based summary files that are available for linkage in the community clinician survey and the nursing home survey. And these basically have respondent level characteristics of the patients cared for. And so the thing we were trying to solve with this is using beneficiary level CMS data, either Medicare data or NDS assessment data. That is a very labor intensive process that really requires sort of special expertise and technical know-how to manage the data, to combine the data into a useful tool for research. And only, certain researchers and certain institutions really have the capacity to do this or have access to the people, can fund the people to help them do this. And so using something called LTC Focus out of Brown University as our inspiration, which is a nursing home level data source where they have used MDS data, Medicare data to create um, nursing home level characteristics that have been used, in hundreds of papers, if not thousands of papers, as a data source. That so individual researchers weren't doing all of this MDS number crunching themselves. We wanted to do something similar. So researchers using these data would have respondent level characteristics of, what does the panel of this respondent's patients look like? And so if you go to our website, you can read more. Right now, this is available for the community clinician survey and the nursing home survey. We have data dictionaries for both. Things, for example, in the community clinician survey are panel demographics, both of the patients with dementia seen in the panel, as well as for all of the Medicare beneficiaries that the clinician sees. Clinical characteristics, where it's like, the proportion with a given CCW flag for a particular chronic condition. And then for a given clinician's panel, what proportion of those patients receive an annual wellness visit, receive neuroimaging of some sort, are prescribed. A lot of my research is on prescribing, and so I'm very interested in how medications get used. And so, what percentage of the patients of the clinician's panel receives an opioid or an antipsychotic? And then on the nursing home survey, so we do have LTC Focus available as a linked data source. The one limitation of that is those are characteristics of the overall facility population and not limited to persons with dementia. And so what we did in our version of these claims-based summary files for the nursing home survey is to have dementia-specific characteristics of the residents and the care that they're receiving. So that's, I think, what will hopefully be a really useful source of claims-based summary files that can really kind of speed the types of answers that researchers can get to by using these data. And then finally, because this community clinician and nursing home surveys have federal identifiers, so NPI or the National Provider Identifier for the community clinician survey, and CCN or the CMS certification number for nursing homes, that means you can link all other various other types of data sources, resources that are released by CMS. In particular, things like the payroll-based journal for nursing homes, nursing home compare data, again, LTC Focus that I mentioned, and then there's also a number of public use files at the provider level, the individual clinician level that CMS releases that we have prepared and available in linkage. And then finally, actually, the real reason that NIA even funded the linkage platform is to have beneficiary level claims and assessment data. And so the way this works is we provided linkage, basically our finder file of all the people who participated in the community clinician survey or the nursing home survey. They then use that information to identify all of the beneficiaries that that clinician provided care for. So using the clinician's NPI, the survey respondent NPI, they can look at all of the billing encounters in Medicare data and all of the prescriptions written and paid for by Part D, and they can identify all of those beneficiaries. So this way, for all the people that participated in this survey, you can link to the claims data of all of the Medicare beneficiaries that they cared for, both with and without dementia. Similarly, for the nursing home survey, by providing the CCN of the facilities that participated, you can link to all of the MDS assessments of all of those individuals. And then through the MDS assessments, you both have those assessments and you can get all of the Medicare and Medicaid claims for those individuals. So this is an incredibly powerful tool to link the surveys to these CMS data resources, and it is all available for free. One or two more slides before I hand it back to Joanne. So how did we do on the first wave? We worked really hard. We didn't quite get to the numbers that we were hoping for. So for the community clinician survey, we had a sample of 25,000 respondents. We ended up with a response rate of on the order of 20%. Nursing home and assisted living and home care, these really were all almost more like sort of pilot data collection efforts in the first year, just given everything else that we had to be doing. We ended up with on the order like around a 20% response rate for nursing home and assisted living, actually a little bit less than that. The bright spot is that once we engaged an organization and then surveyed the staff within the organization, we actually really had quite respectful response rates from the staff on the order of 60 or 65%. So we were really pleased at the response rate of staff once we recruited the organization. If you've had a look at the data, you may have noticed that we did not release data from the home care survey, and that is because our response rate was too small. This was an incredibly challenging survey, which I think really speaks to the nature of these organizations, the turnover. We presented the data collection organization with, a list of organizations to approach, and the first job is tracking down good contact information. And oftentimes, you'd put it into Google Maps and it would be like storefront in a strip mall. So just like lots of turnover, or it would be a PO box, or no one would answer the phone. And so the home care survey is very much a work in progress. Ultimately, in the first year, we did not have enough data to be able to release that survey, but we are working very hard on improving that. So wave two, actually, I'll just show you we're continuing to chase down the community clinician sample. We've boosted our nursing home, assisted living, and home care sample, so it really is truly representative of the whole country, moving out of that pilot wave one phase. And now I'll turn it back over to Joanne.
I'm going to unmute myself first. So I'll tell you a little bit about what's coming. And Donovan hinted at this with the table that he briefly just showed. I think the first thing is that for the community clinician survey, because the timing of the wave two was such that there were not updated Medicare files available for us to add to the sample, perhaps to look for newly licensed clinicians. Instead, we decided to focus on continuing the wave one collection. Essentially, it's a non-response follow-up effort. And so we are piloting different strategies, such as changing around the incentive structure, offering a shorter version of the survey to see if clinicians are more likely to respond to a short version that drops about half the questions, and so on. So we're getting some more information about that, about what clinicians really are responding to when they're making the decisions about what to do in their response. For the nursing homes and assisted living, we have brought in a lot of new organizations that we're recruiting with goals of trying to get 145 more nursing homes and 180 more assisted living. And our data collection partners are making really good progress towards that. And as Donovan mentioned, once we get the organization engaged, their staff response rates are quite good. So we're feeling very optimistic about how that is going right now. And then for home care, as noted in wave one, we started with the Medicare Home Health Agency list, which when we did some spot checks of a couple of different states, it looked like, depending on the state, anywhere between 10% and 30% of those home health agencies also are doing home care. And but that means that there are a lot of home care agencies that are not also doing home health. So we then went through every state and found lists of licensed home care agencies to the degree that they even exist, because in some states those don't exist. Some states don't license home care. So then we looked for things like, are there lists of Medicaid approved agencies or lists from kind of area resource centers or other sources of information about home care lists. We also got from the state of Michigan a list of individual home care providers who are registered with the state of Michigan And we are about to launch a pilot of contacting those people directly to see if we get any responses, how many of them say they ever worked in home care, are they still working in home care? So that's really a pilot and an experiment. So we'll see how that goes. So in wave 3, we are already planning wave 3. We are doing updates of the questionnaires now. Those are in cognitive testing literally this week. And so for community clinicians, we are going to launch a new sample that is going to be clinicians that are in the top quartile in the United States of the volume of patients that they have with dementia for each of the clinician types. Not surprisingly, that third quartile is different for neurologists than it is for primary care providers. And then wave 4, looking ahead, we're thinking we're going to focus on clinicians who take care of people with dementia who are in rural locales. So that'll be for primary care, primarily rural clinicians, but we also may add in specialists who have a relatively large volume of patients coming from rural areas. Because we know that I think Donovan found that there are something like 2 geropsychiatrists in the entire United States located in a rural community. So there probably are referral networks, but maybe not. So that'll be probably where wave 4 is going. For the organization focused surveys, we're going to continue recruiting new organizations. And also we're going to continue a longitudinal follow-up of the wave 1 and wave 2 participants. And one thing that did not make it on this slide is we are going to make a very big effort to try to find individual home care providers that might not be working through agencies. So we are lovingly calling this the fire hose method of we are just going to try every method we can to try to find home care workers. That does not risk us getting hit by bots and scammers. So we will need to work with partners, perhaps training organizations that are willing to do a mail merge and send out individual links to people in their database. Or there are various companies that do payroll. Maybe one of those companies would be willing to support us in doing a mail merge and sending direct links out to their workers. We're not going to do Facebook advertising. We feel, based on our experiences and experiences of colleagues of ours, that actually is risky, and we don't want to have our taxpayer dollars that are going into this research sucked up into bots that are getting programmed to automatically respond to surveys to get the incentives. We also, for wave 3, are adding a qualitative phase. And this is going to involve roughly 30-minute interviews with a large number of individuals of each of the survey types. And when I say large number, we're talking about doing 720 interviews during wave 3. So this is going to be a significant effort. Jarman Ye here at UCSF is leading that team and developing the protocols and the interview guides at this point. For clinicians, we're aiming to target 20 of each of 6 buckets of types of clinicians. And then for nursing homes, we're going to aim for 50 facilities, assisted living, 50 communities, and for home care, probably 50 agencies and 100 independent workers. That's still a little up in the air. And try to have clustered interviews. If the clustering strategy doesn't work for the interviewing, then we're just going to abandon that and generally interview. But we're really excited about being able to add very rich qualitative information to this data repository for the research community to work with. On the next slide, we give you a little bit of a sense about the complexity of this. We're going to be receiving contact lists from our data collection partners. Will transmit through Michigan. We will get those lists of people from whom we can sample. We will then try to schedule those interviews, conduct the interviews, record and transcribe. We are planning to conduct interviews in English and Spanish. The individual will get a gift card. Then we're going to clean the transcript both for accuracy and do an initial screening for privacy. And we'll be adding a bunch of metadata, which includes kind of high-level themes, some other information about things like word counts and some tags to make the data more searchable for researchers, and try to get that information to be fairly well organized. We hope to create public use files from this, but if we cannot, there definitely will be restricted use files, and we do not aim for the restricted use application process to be overly burdensome, but we do want to make sure that we are protecting respondents of people, or protecting their identity. And so there would be a review of anything that then researchers wrote up about what they learned from the transcripts to make sure that the quotes they selected did not inadvertently identify individual people that were interviewed. So next slide, please. Um, so back to Donovan for the wrap up.
Yeah, so wrap up here is the public use files are available through NACDA. And to help answer questions from William in the chat. So I would encourage folks to have a look at the questionnaires that list whether a variable is masked or suppressed. If a variable is masked, I then would suggest that you actually look at the PUF codebook, which it will list the number of respondents for whom the variable response is masked. In some cases, it's a very small proportion of respondents. In other cases, it's much larger. So definitely look at the code book and see how many respondents have that information masked. Ultimately, I think the reality is that most people are going to probably need, in order to publish findings, it's highly likely you're going to need to access the restricted version of the survey, depending on what your specific question is and how much masking there is of a given variable. Um, I would really think of the puffs as useful, maybe if it's a poster or it's kind of enough data to be able to submit an abstract for something, but probably to do an analysis that's going to lead to publication, there's a really high likelihood you're going to need to access the restricted version of the data. So the restricted version of the data are available through linkage at this point. Essentially anything, any type of restricted data, whether you're using CMS data or not, or even if you're only linking the administrator and the staff surveys together, that all happens through linkage. Again, you can find the processes outlined on our website. All of the year one data sets are available now, but as you might anticipate in releasing our first wave of data, it has been a learning process. And so there have been some updates, including, providing more information in the documentation, programming language and SAS and Stata for how to appropriately weight the surveys. So please sign up for our email list, keep your eye out as we continue to release updates with the documentation. And then finally, the whole point of this project, it's all free. Like this is us creating a data infrastructure. When Joanne and I were writing these aims with the team, nothing that we proposed was our own research. This is to create a data infrastructure for other people to use. And it's all free. So our data are free. Any of the linkable data, including the CMS data, is all available for free. And if you've done other research, you know that if you want to just get standalone CMS data, it is very expensive. And again, this is free. So just keep that in mind. And finally, so here's kind of our timeline. The startup, this is a 5-year project. The startup past 2 years have had lots of startup activities with sort of weird timelines as we, did the bid process for the data collection groups. Um, by the time we get to 2026, which is when wave 3 of the survey is going to be fielded, that will kind of get to our sort of steady state 12-month timeline cycle where basically the data collection is beginning at the beginning of the calendar year. That's the year the qualitative data is going to start. So, survey respondents start answering surveys in July, February, and then the qualitative data starts maybe happening in March, April. The prior year's data release will happen in the spring. So wave 3 data collection begins in January of 2026. Wave 2 data release will be later in the spring of 2026. So say around May. That's also when the call for pilot proposals will come out, will be in the spring of the year. So again, wave three is when we will finally get to sort of a regular 12-month cycle, and then 27, 28 will all have a similar timing to what we hit once we get to 2026. And so that's all we had. We over the summer released several papers as part of a special collection in JAGS to sort of describe this project and introduce it to the research community, as hopefully people are submitting proposals to use these data. These would be available for you to be able to cite and learn more. And so that's that last QR code that we have there. So with that, we'll stop and see if there are any other questions to answer.
Yes, I'm looking at the Q&A, and there's a few questions that are related to weighting, and I can answer kind of one or two of them, and then I'll let Donovan answer the rest of them, but I'll kind of group them up. One is about whether there is the degree to which the staff that responded from within an organization might be truly representative of the staff in that organization. Is there any kind of within weighting? And the answer to that is no. The weights are designed focused on the kind of national workforce representativeness. That said, there is a body of work that has been done focused on hospitals overall and on specific units of hospitals, such as that from Linda Aiken and her team at the University of Pennsylvania, and Audrey Linden and her team at New York University, which focused on obstetrics nurses, that have identified recommendations for, like, say, a whole hospital. I believe it's of 9 responses, looks to be as representative as one could expect. And for a single unit, 3 or 4, and or what percent of the staff that you have is probably representative. So we are planning to do some analysis of the degree to which the facilities that actually agreed to participate are similar to the national landscape of organizations. That we can do that for nursing homes. It'd be very difficult to do for assisted living because there's not a lot of national data on them. We do wonder if the nursing homes that agreed to participate might be better than the average. And so we're going to be doing some looking into that and some documentation of that to help provide you with some guidance about what that might look like. Let's see, another related question about the weighting that Donovan might have already typed the answer to, which was related to how to use the weights in the system. Kind of should you use weights, and how should you use weights, and will we have sample code available for you?
Yeah, so the answer is yes, you should please use weights. James is finishing the drafting the documentation around the appropriate way to use weights, accounting in particular for clustering in the staff surveys of respondents within organizations, a sample code for both SAS and Stata, and that will be part of a documentation update that will hopefully say be released in October. So that is coming very soon on the weighting topic. At this point, we have the data files are available in SAS and Stata. If there's additional demand, say for SPSS, I can put that on the list and see if we're able to also offer the files in that format as well. Um, on the restricted application front, you do need to have IRB approval from your home institution to apply. And I understand, that can vary how long that wait is at different institutions. What I can say is we try very, very hard to turn around our end of the application really very quickly, and basically aim for on the order of 5 business days to have an answer back once we receive your proposal. So we usually have a quick turnaround. However, if you want to access CMS data, either the beneficiary level data or our claims-based files, then you do have to go through like the linkage CMS access process, which does add some more time to the process. Um, so hopefully, from submitting to us, until having the answer back from linkage um, and NIA for approval to use the CMS data. I would hope it would be on the order of 6 weeks or so. If it's restricted access for just NDWS data, either just the surveys or anything that isn't CMS data, it's a much faster turnaround. Again, we would aim to have you an answer, within basically a week or so, and get you set up in the enclave pretty quickly.
All right. I'm going to answer a question quickly, and then I think there are a couple of other questions that are better answered by Donovan. One is about using lists from licensing boards, and noted that in their area, their board of nursing licenses home health aides. I'm going to make a terminology note here. Actually, home health aides and certified nursing assistants are generally registered. Generally, they are not licensed. There are training requirements, but it's not quite the same thing as licensure. And often becoming registered has no cost to them or a very, very minimal cost, and often does not have renewal. There may be some states where that's an exception, but that is the exception and not the rule. Thus, if you go to a state and try to figure out who is a kind of registered certified nursing assistant or a trained and qualified certified nursing assistant, in some states there might actually be 10, 20, 30 different training providers that are approved, and you would need to go through their training lists to try to find those people. Then you don't know if they were renewed their training properly. These lists are often not updated. Mallory Johnson from UC Davis just published a really nice paper on this a few days ago. So I encourage you all to go look it up to give you a sense of the complexity of the state level data about the certified nursing assistants and home health aides. And home care is, quite frankly, the Wild West. There are a lot of people that directly hire home care aides, train them themselves, pay them cash. I don't know that we're going to be able to find people who are paid cash very easily in our next round. But there are a lot of people that are not through agencies, not registered, don't have formal training, and are honestly going to be pretty hard to find. But we're going to try to find them. That is one of our goals, is to figure out how to really get a good sense of that home care workforce. So it's super complex. And that is why we began by using an organizational strategy. Plus, the organizational strategy does give us the advantage of being able to connect those individuals to the organization that they work for, which then provides us with some opportunity to look at quality of care and the characteristics of the staff. Now, a couple questions that came up for Donovan. One was, will there be some STATA sample code posted? That there's SAS code samples, but not STATA yet.
I'm pretty sure the answer to that is yes, in particular, since we have the data available in Stata. And the last quick answer, now that we're at the end of the hour, zip code, no, zip code is not available to researchers, even in the restricted enclave. Um, you, yeah, no zip code. The
Yeah.
only geographic data available are what's currently available in linkage.
Although I would note for organizational linkages, such as the nursing homes, that is the part of the information of the facility, but we wouldn't have the zip code of where the individual respondent staff member lived.
With that, I think we'll stop and say thank you all very much for joining in. Please use the data and
Yes, and
sign up for our mailing list.
you can email additional questions, and make sure you're on the mailing list so that we can continue to keep you updated. Thank you
Thank you
much.
all.